the work that we do, how to write about development, how to write about the impact that a lot of the development partners are doing in the country. And as such, we also are planning a media engagement further in the beginning of next year, where we can sit further together to explain ourselves to each other, and to also help ways of breaking this kind of work that we do to levels that can be consumable to the general public. I want to believe we are starting, or we have started, and I'm going to be handing over to the director. He's the host, the director from the Department of Information. Oh, I'm told I should keep going. They are setting up, but I've done whatever I wanted to say. But we really are privileged. Like I said, we want to start a relationship with journalists, especially because you are the watchdog. You are you call truth to power. I mean, you call truth to power. So it's when you know the information of what's happening, you can then challenge status quo. That the research says that. So what is this not happening on the ground? So we believe that as a research institute, we have also a responsibility to engage you more, to see how ways of re-improving countries or populations that we work in. We are headquartered in Malawi. We also have offices in Kenya. What else can I talk about? So like I said, I'm I've been in Malawi since months ago. I came in Malawi in July. The theme of this, director is showing me that I should talk about the theme. Yes, the theme of this event is achieving universal health coverage, and we cannot do without family planning. So we really are going to be talking a lot about family planning, what the success of Malawi in this area, because Malawi is one of the exemplar countries, countries that are doing really very well in the rolling out of the contraceptive. It has the, what do you call it, the modern contraceptive rate. It's doing very well. It's among the highest, and therefore it is regarded as an exemplary country. And AFIDEP is with other is leading a consortium where we are investigating what led Malawi to where it is, and what other countries can learn from that. And therefore, this is an important session in a lot of context, in that we are going to be an example to other nations in Africa and the world that are not doing so well. So what lessons can be gleaned from what Malawi has been doing in the last 3 decades. So that's why we have representatives from Ministry of Health, who are the custodians of this family planning, and we have UNFPA, which is really, you can see the pull-up, but ensuring reproductive rights for all. So UNFPA in the space of family planning, in development space, they are really the authority in that area. And we have Sandra from Palladium, who are in the family, and we have our executive director, Dr. Elia Zulu, sitting there. So thank you. I have talked. I can give the mic to. We are waiting for them to start. Okay, we are ready to start. Thank you very much. I'll be handing over to director to start to continue. He's our host, director from information, and thank you very much.
Thank you. Thank you very much, Director of Ceremonies. Dr. Elia Zulu, the Executive Director of AFIDEP. Ms. Mary Mlombe Piri, the Chief Reproductive Health Officer from the Ministry of Health. Madam Naledi Nodrigues, UNFPA Country Representative. Ms. Sandra Mapemba, the Country Director for Propel Health Malawi. Colleagues from the government present. My colleagues from the Department of Information. Members of the press, ladies and gentlemen. Good morning all this morning. On behalf of the government of Malawi, I welcome you to this momentous occasion of sharing Malawi's successes in family planning and adolescent and sexual reproductive health and rights. Malawi's success is derived from a mix of things: formulation and implementation of important policies and strategies, successful family planning program implementation, and increased and increased global attention and financing for family planning. Today we'll hear from partners of the Malawi government on how we made these strides and what this means for the country. To you, our journalists, I need to highlight that these are significant national issues you need to address with urgency. You may be aware that population, especially overpopulation, is an important issue in many ways, including but not limited to the depletion of natural resources, degradation of the environment, rise in unemployment, high cost of living, water shortage, just to mention a few. Hence, for Malawi to experience increases in contraceptive prevalent rates is significant and worthy to celebrate because it may, among others, help us manage the population growth. In 2021, Malawi government launched the 2020-2025 digital health strategy with a commitment in improving the flow and use of information in support of the delivery and management of healthcare services, and it is a role of the Ministry of Information through my department to ensure that our mandate of promoting and facilitating access to information is enhanced through frequent contact and dialogue with the press and various stakeholders. That is why we are here today, to fulfill that mandate. We also provide policy direction and guidance in the production and dissemination of public information and management. With these remarks, let me welcome you and thank you all. However, we've got Dr. Elia Zulu, the Executive Director of AFIDEP, as he will share with you what makes Malawi an exemplary country for F&P and ASHA, the criteria used to define exemplar countries, and as you trace Malawi's performance through the years. Madam Mary Mulombe, the Chief Reproductive Health Officer from the Ministry of Health, will share with us how have policies and programs changed over the last 3 decades, how the Reproductive Health Directorate facilitated the successes we are celebrating today, how Malawi benefited from international protocols and treaties, and we have Madam Rodriguez, the country rep for UNFPA. She's going to elaborate on the she'll highlight on the mandate of her organization, including the financing of family planning programs and the role of international agencies in the family planning area. Lastly, we have Madam Mapemba, the country director for Propel Health Malawi, who will share with us on how international agencies help shape policy to ensure that Malawi increases access to family planning, how the government is financing the programs, what should we do for sustainability, and how family planning services provision, how family planning services provision in emergencies are done. Colleagues and our high table, I would like to welcome you to this function and also indicate to you that today we're celebrating the success stories. And for a country like Malawi to reach this extent, it means that the various stakeholders have indeed put a great initiative for us to reach these strides. Without taking much of your time, the floor is now open. Over to you, Dr. Zulu.
Thank you very much, the director and other panelists and the members of the media for joining us this morning. I really just want to emphasize why we are here today. the global community now is moving towards how we learn from each other, what countries should learn from one another in order to address challenges that we are facing. But I think as I begin, first of all, I should try to put the question on the table: why should we care about family planning? Family planning seems to be a very, very individual issue. It's women and their partners and so on. But why should we care as a nation? Family planning is important because by allowing women and their partners to freely decide when they should start having children, when they should have that children, how the spacing of the children should be, and when they should end having children. By allowing women and their partners to make those decisions, family planning becomes a very, very empowering tool for empowering women, but also more critically, it has far-reaching benefits for the health of the women and their children, for the economy, because it allows families to really have the children that they can feed. It allows families to have healthy children, to have children that they can send to school. It has far-reaching implications on the environment. By allowing families to have the children that they have, family planning helps to reduce the incidence of unplanned pregnancies and unplanned deaths, which also leads to the pressure on the land, the division of the land that we are seeing around the country. So family planning is one of the smartest investments that a family and a country at large can make, because its implications on all the sustainable development goals is quite far-reaching. For instance, it's noted that from work that was done in Zambia, that if you spend $1 on family planning, it helps you save $4 in other health and development areas, including maternal health, immunization, malaria, education, water, and sanitation. That investments in family planning and other reproductive health services can help to reduce newborn deaths by 44%. It's also estimated that for every percentage point in fertility reduction that we can experience now, per capita income, per capita GDP growth will increase by about 25% over the next 20, 30 years or so. So we are talking about a product that is personal in many respects, but has these far-reaching implications. And and so how has Malawi done on this? As I said at the beginning, we are really talking about what is the quickest way that countries should learn. Countries are grappling with different different development challenges, but there are some countries that are making progress. So rather than reinventing the wheel and everybody trying to act like you want to do things your own way, there's now this movement to say, look at these countries that are exemplars, that you would say against all odds. Countries that are experiencing the same challenges that everybody else is experiencing, they are able to make progress. What can we learn from them? So AFIDEP and the other partners here, we are really here, part of this global community that is trying to identify drivers of progress at policy level, at program level, but also at political leadership level to see what is really driving change. So if you look at the case of Malawi in terms of family planning, many of you probably know that family planning was actually banned in Malawi in 1969 by the government then, because it was seen as being against the Malawian culture, that people should have children the way they want to have them. Why are you interfering? It was banned in 1969, but due to efforts, due especially to medical experts in Malawi, who went to our founding president to say, by depriving women of family planning, we are having a lot of problems. Women are having children too close, and a lot of women are suffering because of gynecological and all sorts of problems. The president in 1982 approved that family planning should be reinstated in the country. So from 92, you can see that a country from 69 to 82, there was really no family planning activity. But from then, you look at 1990, that was 1982, The family planning program even started as a child spacing program because people were saying, oh, we're not talking about family planning, we're just talking about child spacing. Because that, even in the traditional culture, has been the focus of making sure the woman should rest between births. A child should grow a little bit before another child is born. So that was the concept. But down the line, when it was realized that Malawian women and partners and families were not as opposed to the family planning, to family planning, things started relaxing. I think Madam Piri here will talk more about that. But what I want to say is that in 1992, only 6.3% of married women in Malawi were using modern contraception. 6.3. That is 1992. You go to the year 2000. Those numbers increased to about 20%. To the year 2010, it was about 32%. 2015, now by 2015, 45% of married women were using contraception. It's estimated now that around 2020, about 58% of married women in Malawi are using modern contraception. So you are really looking at a country that started more or less from zero in mid-80s to being among the highest. 58% is actually not highest only in Africa, it's among the highest globally. When you look at all countries in the world, there are a handful of countries where contraceptive use is reaching about 70%, 65, 70%. Even the richest countries, you see that they are in that range. So Malawi is like now about 5 percentage points even being among the very, very highest in the world. So the interest then is what has happened? Why has the country, I mean, we talk about a lot of challenges, but Director, as you said, in our country, how has the country that is not so rich, that is, how has the country done this? So the international community is interested to find out. And as part of this project called Exemplars in family planning, the idea was to identify about 5 countries that are representing key regions of the world, in Asia, in Latin America, in Africa, but even within Africa, different regions, to say which are these countries that over the last 30 years have experienced the most progress that you would really not understand when you look at the socioeconomic improvements in the country. As you know, our socioeconomic progress hasn't been as dramatic, but when you look at these health improvements, there's a big question mark there to say, wow, Malawi has done this, what have they done? So the other countries that are categorized in the Exemplars project, after doing that analysis that shows countries that have made the most progress, the other countries are Kenya and Senegal. So at the first stage, 3 countries were selected. But as you might know, even when you compare Kenya and Malawi, Kenya was one of the countries that we call the pioneers of the contraceptive use revolution in Africa. They are the ones who started really increasing contraceptive use in the 80s, in the 90s, when Malawi was at that very, very low level. But Kenya in 2015 is still at around the same level. 2020, it's estimated to be around 46% when Malawi is almost reaching 60%. But it's still an exemplar itself because it provides a lot of lessons. Senegal, although it's also an exemplar, but Senegal is mainly representing the Francophone West Africa, which is further behind. And even as an exemplar now, Senegal is around 20%. So you can see that even among these exemplars, Malawi is really the exceptional country that is reaching those globally, what you would say, really beyond the global average, not only looking at Africa and this region. So that's the 3 countries that are being studied. What we'll do here is to share really the story about Malawi. What has really driven this? What did Malawi change? What happened? And we'll hear a little bit more about this. But another issue that I want also to highlight is that apart from looking at family planning, there's another program that the Exemplars in Global Health Project program is looking at, which is which are the countries that have made the most progress in reducing adolescent birth rates. The countries that are really making sure that You know, we shouldn't have, girls shouldn't become mothers before they become adults, right? Which is one of the things that as a country, we are fighting here. In October, AFIDEP actually had an event with the First Lady, including UNFPA, where we talked about how do we fight adolescent teen marriages and teen childbearing and so on. Because we can't achieve Vision 2063 if we continue having half of our girls getting married before they reach age 18. For us to achieve Vision 2063, girls need to complete secondary school. And for us, we can't do that when we continue having the high rates of teen pregnancy. So in this other project, which now AFIDEP is leading, we are looking also at identifying countries that have made the most progress in reducing adolescent birth rates. And in this category, Malawi has also been identified as one of the exemplars. Alongside there's Malawi, the other countries are India, Malawi, Cameroon, Ghana, and Rwanda. But I think one key thing that we need to know here, which is also very critical even when we talk about family planning, is that when you look at the trend between the year 2000 and 2020, Malawi's birth rate among young people 15 to 19, in 2020 it was 164 births per every 1,000 girls. By 2019, that number went down to 86. So there was a reduction of about 50%, which is quite remarkable. But what you will note is that even at 86, Malawi has one of the highest adolescent birth rates. So it's unfinished business. In terms of rates of progress, we've made progress, but we are still among the highest. And you look at maybe when you compare Malawi, we still have one of the youngest, among the 5 exemplars, Malawi has actually the youngest age at first sex. It also has the youngest age at first marriage. So although in terms of reducing adolescent birth rates, which means a lot of the work that partners sitting here have been doing has been having positive effects, you see that it's really, we are still at a high level. So there are lessons other countries can learn, especially countries at high level, but it's a pretty much unfinished business. And I think that relates to the issue of contraceptive use. When you look at the numbers I mentioned, that overall, young women, married women, about 45% in 2014, and now close to 60% in 2020 are using modern contraception. When you look at unmarried young women, it's only 32%. Who are young unmarried women who are sexually active, it's only 32% who are using contraception. And I think that's part of what is contributing to the fact that Malawi still has relatively high adolescent birth rates, despite the fact that, of course, we've made some progress in this. So this is what I really wanted to highlight here, that it's a remarkable story. We had the International Family Planning Conference in Thailand just last month, and really Malawi was being highlighted there as really a country that, against all odds, if you use those words, Malawi has achieved so much. So it's something that we should celebrate, but at the same time we know that there are still gaps in there. There's still unfinished business. There are still some women who are not accessing or using family planning the way they need to use. You analyze data from 2015 in Malawi, 53% of all pregnancies in Malawi were unplanned. So it means that there are still a lot of gaps in there, although the country is doing very, very well. So I'll hand over to the next speaker, Madam Director. What I really wanted to highlight is that story about how the information that has been analyzed to show that Malawi is really a true exemplar in family planning, but also to a large extent in reducing adolescent birth rates. For the adolescent birth rates, I think we're mainly looking at the regional representation where Malawi is. While family planning, as I said, it's global. Thank you.
Thank you very much, Dr. Eliazuru, for setting the ground. I'll actually take you through the family planning program. There are 3 areas that I will actually address. But first of all, let me bring you let me take you to an attention to say universal health coverage is a key goal for the government of Malawi. This entails making the health services, including reproductive health services, among which is family planning and also maybe adolescent health issues, available, accessible, and affordable to all Malawians. Universal health coverage cannot be achieved if family planning is left out of the equation. As the government recognizes the important role that family planning has, not only on improving people's health, but also as a key for achieving the social and economic well-being for our Malawians and also for the nation. So as such, I will actually outline how the policies and programs changed over the past 3 decades, before 1990, and also years after the year 2000, then from 2010 to the year 2022, as we are approaching the year 2023. In passing also, I'll be mentioning how Malawi benefited from the international protocols. There are so many, but actually I will try and on the family planning 2020 commitments that Malawi made in London in 2012, the International Conference on Population and Development, and also the Maputo Plan of Action, including the Abuja Declaration. And thereafter, I'll actually take you on how Malawi facilitated the success we are celebrating today. So as already alluded, family planning was actually introduced in the 1960s. It was banned in the 1970s and reintroduced in 1982. These have already been elaborated. So by then, the program policies did not support family planning. They were restrictive policies. Only married women were allowed to use family planning methods, and not adolescents. And maybe even the men were not even able to reach out. It was actually a program supporting maternal neonatal. A neonate is a newborn baby before 28 days health. And it was also focusing on spacing and not limiting. So as such, we would say the women who were supposed to access the services were even supposed to get husband's consent. So you can see that maybe in this we were able to actually violate issues of equity, promoted discrimination, and also issues of women empowerment were not adhered to. So in 1994, this is the year when we had the actually more effort that was put in place, and also to the program, not just family planning, but even the sexual and reproductive health program. So this was the time when we had Malawi actually attended and adopted the International Conference on Population and Development commitments and also the program of work. So before this as a program, we had our first family planning policy. And by then, even the SRH policies, we had parallel policies, each program under the sexual and reproductive health. And also maybe other of the programs within the Ministry of Health, they had specific policies. So as family planning, we had our own policy. Adolescent health, they also had their own policy. The maternal, neonatal, and child health, they also had their own policies. So we had different parallel policies. So by then also, as a country, we had a few interventions. This is when we introduced the community-based distribution of family planning. We had some volunteers who were issuing the community level. And this was also the year when we saw the coming in of our public-private partnership, the coming in of Banjalan Sogolo with a few sites. So by then, we had only 2 family planning clinics. That was in 1983. But with the efforts that we made, we increased to 210 family planning clinics by the year 1995. The services were being provided in 5 days rather than maybe once or a day within these services. So this is how we actually moved. And also the coming in of after Malawi attended the ICPD conference, we saw that as a program, we adopt a rights-based approach in the family planning program. And by then, this was also the time from the year 1992 to the year 2000, the ban on husband's consent, uncle consent for a lady, a married woman, to use contraception was actually removed. And we also increased the sites for service delivery. And then we also adopted the integrated sexual and reproductive health and rights policy. So provision of our services were rights-based, and then with that in 1998, we moved to have one integrated sexual and reproductive rights policy from the commitments and the recommendations we drew from the International Conference on Family Planning and Population and Development in Cairo in 1994. In addition to this, that's when we saw the coming in of the National Population Policy, and also the coming in of the gender policy. And this supported us to actually also ensure that our women are empowered to actually make a decision on number of children, on also access to services. In addition to this, we also ensured that from the year 2000 to 2010, we also ensured that we also mandate the HSA, the lowest cadre in the Ministry of Health, to provide the services at community level. As the community-based distribution agents were providing pills and condoms, the HSAs came in to provide the pills and condoms and also to offer the injectable contraceptive at national level. So this is how we fared, and also we ensured that we actually updated the pre-service so that from the nursing school, all the providers, whether doctors, nurses, clinicians, they are able to provide the contraceptive method mix. We call it a mix because we have all the implants that are seated on the arm, the pills, and the vasectomy tubal ligation. So this is also how we fared. And also from the year 2010 to the year 2016, after we adopted the ICPD, the commitments, we also saw in the coming in, we also actually committed to the ICPD at 25, and this was in the 2019, where we, as Malawi, came up with the 10 commitments for the ICPD after 25 years of committing. And also same from the year 2010 even to the year 2022, we also committed to the Family Planning London Summit, where now we wanted actually also to reach out to the adolescents, the 15 to actually 24, and also included the 10 to 20, the 10 to 14, because we are also seeing that they are having sexual debut at an early age, and also they are actually having children. So in these commitments as Malawi, we actually committed to actually do more on service delivery. We also do more on reaching out, taking the services to the end user, even in hard-to-reach areas. We also actually are committed to increasing financing for family planning, such that we also worked with our parliamentarians. And as of now, we have a budget line of family planning. We started with 26 million in 2012. And as of the year 2020, we have been issued 475 million, and this is from the government to show their commitment, in addition to the support that we get from our stakeholders. And also, this is the year when we have actually have the revised population policy, and also issues to do with the FP 2030 commitments. We are now have the family planning 2030 commitments. So this is just how Malawi actually changed the policies. And also on how we have benefited from the international protocols, as already said. The first protocol, there are so many, is the International Conference on Population and Development, the Cairo Conference in 1994, which actually supported the government or the ministry through the Reproductive Health Directorate to actually ensure that all our SRH services, including family planning, are rights-based, having an integrated policy, and also ensuring that we are able to implement the achievements that we have actually made. The other protocol is the same, the Family Planning 2020 commitments, which government committed in 2012 in London to reach out to every 60 out of 100 women with our contraceptive methods, and also including the 15 to 24, and as government we are also taking on board the 10 to 14. The other also is on the Maputo Plan of Action. Actually, this one was actually mostly on ensuring that we had to come up with a roadmap for the acceleration of the prevention of maternal mortality, even the morbidity, the deaths, and also the complications that the women also face. And also the neonatal. The neonate, as already said, the newborn child before the age of 28 days. And the other one on the Abuja Declaration, where actually also we are supposed to actually have an allocation to provision of our SRH services. Now, with the coming in of the Family Planning 2020 commitments, that's when we are saying we also have a budget allocation on family planning. Now, moving to the last point, how we have facilitated the success. I think these have already been elaborated, that now we are an exemplar study. Key to this was as already the 1994, when we actually had the ICPT, and also this was the time when we saw most of the changes in our family planning program as far as Malawi is concerned. And if I can recall, when we had the then president in the multi-party era, it was announced in parliament that family planning is an important strategy for development. That's why we are also saying that even the essential health universal health coverage cannot be achieved without family planning. Even the socio-economic development cannot be achieved if family planning is not achieved. And this is also the year 1994 when the Malawi adopted the national population, the national population policy. We saw so many changes, and already, as already alluded, most of the bans associated with family planning were uplifted. And also, we saw the improvement of women's rights, and also the coming in and the repositioning of family planning and sexual and reproductive health issues in the issues to do with development. So as the ministry and the directorate, we have ensured that we have friendly policies, and that we also have the friendly policy environment that are well supported by government, even the parliamentarians, the various stakeholders, donors, CSOs. We also have our policies like the health sector strategic plan, whose goal is to achieve the national health coverage, leaving no one behind. As such, all the policies for the implementation of sexual reproductive health, including family planning, we are also adopting from the universal health coverage, leaving no one behind. We have successfully executed the national sexual and reproductive health policies, from the parallel ones until the integrated ones, and as of now we have mostly the updated policies, strategies, and guidelines. We also, like in the family planning program, we, after committing to the London Summit, we came up with a family planning costed implementation plan that covered the year 2015 to the year 2020. And also we had an addendum to the costed implementation plan basing on the gaps that we had. As of now, we're in the process of developing a family planning costed implementation plan 2, of which maybe will be launched next year. As such, all are being implemented. All policies are being implemented in the context of the health sector strategic plan. And we are being informed by use of evidence. As of now, we also imply the evidence that our adolescents can use any of our contraceptive methods except the permanent methods, the tubal ligation, known as kutseka kwa amai, and also vasectomy, because we have actually to cancel them, offer the necessary options before they actually are provided with the method. And in addition to that, to the program to be actually successful, we employed the 10 rights-based principles and of the family planning program dimensions. So throughout those phases, the pre-phase, we saw that most of the principles were being violated. But actually, when we actually employed the first phase for the program, which covered the years 1992 to the year 2000, we actually had to address the issues of equity and discrimination. And from the second phase of the program, 1992 to the years of the year 2000 to the year 2010, we addressed issues of quality and empowerment. So in the phase 1, the 1992 to 2000, we were able to reach out to 7%. We were at 7%, as already alluded by Dr. Eliazor, but we managed to move from 7% to 26%. So we were able to reach out to every 26 out of 100 women who were using our contraceptive methods. From the phase 2, which covered the year 2000 to the year 2010, where we had to address issues of empowerment and quality, we managed to reach out to 42% from the 26% of our women who were also using our contraception. In phase 3, and this is covering the year 2010 to the year 2016 of the National Family Planning Program, we employed all the principles. What are these principles? Agency and autonomy, availability of services and information, accessibility of information and services, acceptability. They should be able to actually accept the services, informed choice, issues of quality, issues of empowerment, issues of equity and non-discrimination, informed choice, transparency, and accountability. So in this, we saw the increase from the MCPR that was at 42, we reached out to 62%, as already alluded. As of now, we are now in the commitment phase for the National Family Planning Program, where we committed in 2012 to reach out to every 60%, and in the year 2030, we have also recommitted, because in 2010, despite our commitment, we only realized 49% coverage for all women, including the adolescents, on use of our contraception. So by the year 2030, we want actually to also reach out to the 11 percentage points that we did not do well. So we have recommitted to the 60% again. So as of now, we also ensure issues to do with quality, sustainability, so that we are able to actually realize the gains. So this is all that actually I had to present to you on the policies, changes, the benefit from the international treaties, and how as Malawi we have managed to facilitate the successes. Thank you.
Thank you very much. We are going to be handing over to the UNFPA country representative, Ms. Nelida Rodriguez. You're welcome, madam. Rodriguez.
Yes, it's okay.
Oh, thank you.
Thank you very much, and it's a pleasure being here in this press conference. Thank you for inviting UNFPA, and allow me to just first to the Minister of Information Directorate who has been guiding us on what are the aim and the theme from this press conference, members of the press, Mr. Elia Zulu, the Executive Director of AFIDEP, and Ms. Mary Mulumbi, the Director of, the Chief of Reproductive Health and Family Planning. It's a great pleasure hearing you, and I am glad that I am talking after you, because I've learned a lot on what is the basic reasons of the Malawian success story. And all of other government members present here in our discussion and for the press conference. The United Nations Population Fund, we called UNFPA globally to make it easier and to have it harmonized. Our mission, we identify ourselves as a reproductive health agency, including family planning. And our mission is, of course, to deliver a world where every pregnancy is wanted, every childbirth is safe, and every young people's potential is fulfilled. We aim to achieve the three world-changing results by 2030. And the deadline for achieving the Sustainable Development Goal as a mark is very challenging, and this is why UNFPA has established and decided and engaged on supporting globally all of the countries to achieve what we call the 3 zeros by 2030, where we will be measuring the Sustainable Development Agenda. To ensure that one of them is the zero preventable maternal death, zero unmet need for family planning, and this is the key and core one, and zero gender-based violence, including harmful cultural practices. So keeping family planning as the central and remaining at the central to the achievement of those results is what UNFPA is globally trying to do and to support in the next years. The importance of sexual and reproductive health and rights, and in particular family planning, are now well recognized, and I think that we have heard from Mr. Zulu and Ms. Mulumbi on what are the reasons and how this is really critical to the economic development and the full development of a human being and on their rights. So when FPA, we believe that the family plan, the reproductive health and rights, and including family planning, is not only improving the woman's chance of surviving pregnancies and childbirth, but also contributing to the relevant issues such as gender equality, and it has been very well highlighted here, better child health, and improved response to HIV, greater education outcomes, and poverty reduction. In other quarters, family planning has been described as the vaccine for maternal morbidity and mortality. I think that we have heard from the two panelists who preceded me how having a child when desired is a fundamental component of our life as humans. The right of individuals to found a family and decide freely and responsibly the number, spacing, and timing of their children, and to have the information and means to do so, featured in International Home Mix document as early in 1948. So this is clearly linked to the first and basic human rights defined and declared in 1948. So these rights serve as a foundation to address the reproductive needs of the population. And family planning was central component of the ICPD 1994, as has been very well explained here by Ms. Mulumbi. And it has been driving to many countries I would say all of the 179 signatories of the ICPD in 1994, the ICPD Plan of Action, they have engaged themselves in any mean. Some countries taking the 94 as a mark and defining a full reproductive health program, and has been for us very well explained how Malawi did it, and many other countries, and this has helped on moving the rights on contributing to the enjoyment of rights to health, including sexual and reproductive health and rights, and including family planning. Under the Family Planning 2020 targets, we have heard how Malawi has successfully achieved, as explained by Ms. Mulumbe and Mr. Zulu, almost 60% of modern contraceptive prevalence rate for married women and 45 for all women. Of course, we are still in the position where we need to have some more evidences on what is the real situation, what are the main reasons, and how this success story that Malawi is showcasing today toward increasing a remarkable modern contraceptive prevalence rate during the last years and the last decades and years will be told by many, and the contribution, how these have been also been multifaceted. We have heard some of the reason and the historical evolution of this. It is good to continue exploring and studying and sharing this success story with other countries. So moreover, a favorable legal and policy framework. We have been hearing from Ms. Mulumbe on how Malawi has adopted this favorable legal and policy framework, promoting access and utilization of modern family planning methods among adolescent and young people including. At the same time, and this is something calling UNFPA and all of us, all of other partners attention, at the same time the unmet need for family planning is still high among adolescents and young girls. And this is something that call our attention as reproductive health and family planning actors in the country, and how we can better support the young people to fulfill their potential. The adolescent birth rate is still, from our perspective, remains unacceptably high. And this is something where we need to look at the rights of adolescents and youth. Despite all of the improvement, all of the achievement, good achievements, there is still something to be done. And we are engaged on looking at it. Allow me also to highlight some other good examples from Malawi. We had last month, the government of Malawi signed the compact with UNFPA. And its commitment to ensure that family planning commodity is available every year, everywhere, and for everybody. The compact will ensure UNFPA continues to support procurement and distribution of reproductive health commodities in the country and up to the last mile. The compact will also enhance the fulfillment of the commitments, all of the commitments we have heard here from the reproductive health focal person and family planning focal person. This will help to fulfill those commitments, and all of the commitments that Malawi government toward ensuring the unmet need for family planning, expressed through instruments such as we said before, the International Conference on Population, the engagement. The country has been showing very clearly this engagement and commitment. The Family Planning 2030, it is very clear engaged, and the Maputo Plan of Action in 2015. The Country Compact will also be critical to contribute to the achievement of the Sustainable Development Goal targets. And we have heard from Ms. Mulumbe on how the achievement of ensuring the universal access to contraception by 2030 is a commitment from the country. So from UNFPA, we are glad to see that the compact will help on also ensuring that those sustainable goals are ensuring. As well as realizing its aspiration as enriching the Malawi 2063 vision and the 10 years implementation plan. The Malawi's commitment to increasing the budgetary allocation for family planning commodities also is something that we would like to highlight. We have heard, and we are really one of the witnesses of the engagement of government of Malawi, who has been increasing the allocation in the national budget to procure family planning commodities, while the global expectation is that each country should be expected to contribute to a minimum of $10,000 US. The contraceptive procurement, Malawi has already surpassed this threshold, as we have heard, and this evidenced by the total over of $400,000 US, which was appropriated in 2021-2022 national budget. And this has since been remitted to UNFPA for the procurement of contraceptives, which we are supporting to the country. The UNFPA, in collaboration with other partners, we have mainly USAID, continues to mobilize resources to ensure zero stock out for family planning commodities, and first through the Health Sector Joint Fund. Donors such as the Foreign Commonwealth Development Office, FCDO, German and Norway governments. We are partners that continue to contribute toward the procurement of family planning commodities through the Health Sector Joint Fund. UNFPA continues to procure family planning commodities on behalf of government of Malawi at a very competitive price, which allow for more saving and more commodities for the country. So today, allow me to highlight and to express my really happiness, and even I'm proud of being in this country and saying that we celebrate this achievement in Malawi, and we are contributing to this national achievement, and we continue committed to support on going on this path. Thank you very much.
We can go ahead, Sandra. Welcome.
Thank you. So I'm Sandra Mapemba. I'm the country director for Propel Health, Malawi. Propel Health is a global project. It's a USAID-funded project, and it's a 5-year project that is a follow-on from the Health Policy Plus. And our mandate under Propel Health is to really support local organizations, governments, civil society organizations, and young people's organizations, led or focused, to really contribute towards the vision for Malawi, the policies, the implementation, what we should be doing so that we can be efficient as a country to reach young people, to try and address the issues that my colleagues here have outlined. Today I'm really going to be talking about the health financing space and how the international organizations and agencies have really supported Malawi to come to the point where we're an exemplar country. And the critical thing, starting from 1982, as people have been talking about, has been political will. Political will has really led the country to the place where it is now. Without sound policies or government's input or acceptability on the use of family planning by each and every person who is eligible to use family planning, we would not be here today. So the role really of international agencies has been to support government, to translate policies, global policies. So you've heard about the ICPD, you've heard about the FP 2020, you've heard about COP23. So the role of international agencies is really to discuss with government if, first of all, they would want to be part of that global initiative. And secondly, to make sure that those particular policies translate right down to that beneficiary in the community, right down to the last mile, that last household, that last young person that we are seeing, so that we reduce this population the population boom that we're actually seeing. So the critical thing has been the partnership between international agencies and government agencies, and the political will to buy into these global thinking and global frameworks, and then to localize these, to make these Malawian, to make sure that we are engaging our fellow Malawians to ensure that we have the socio-cultural pieces that we are always resistant to. So Mary brought up the fact that, you know, people are kind of resist in the beginning for family planning. Dr. Elia highlighted the same. But as times evolve, change evolves, the government has been open to that. But we cannot implement without understanding how those beneficiaries would want to receive the commodity and where they would want to receive the commodity. So international organizations have partnered with government to provide the funding to ensure that these consultations are done, so that when policies are finalized, they are homegrown. They are not just replicas of a global or regional instrument, but they talk to the livelihoods of Malawian people, the everyday expectations of Malawian people. So that's been really critical. Key to the financing for family planning programs has been the US government, who is the leader in actually supporting these, closely followed by the UK government. UNFPA, as a multilateral organization, has been critical in providing some more support, as they've talked about the compact now, which provides the commodities for the country, but also to provide the guidance through the ICPD agenda and where the focuses should actually be. And we have World Bank, who comes in to support family planning programs and even offers countries loans, probably through under the GFF, the global financing facilities, so that we can make sure that we have a healthy, productive population. So family planning allows for this healthy, productive population. And why do I emphasize on this? If we do not have family planning, we will have people giving birth without spacing their children, which increases the population boom, sure, but it's detrimental to the woman's health. And with each pregnancy that she has, her health is deteriorating if she's not able to space that child. But then we also have the teenage pregnancies that were brought up. And you have all these young children getting pregnant when they shouldn't be getting pregnant if a contraceptive is available. When a young girl does not have access to contraception, she will become pregnant, she will drop out of school, she will be less competitive on the job and development market, she will be more susceptible to gender-based violence, and basically, she will have been robbed of her childhood and the ability to perform and really be productive on the Malawian development stage. So we critically need to look at access to family planning. This is a lessons learning. So we've said Malawi has had the international support to kind of look at different policies. Mary mentioned the FP 2020 commitments. Under those commitments, Malawi committed to actually having a family planning commodity budget line within the national budget. Through the support of international organizations, through their flagship programs, we supported the government to engage with the members of parliament to ensure that there is a budget line within the national health budget. And in 2013, though it was small, as I said, because of the political will, the MPs rose to this occasion, and we got 26 million to buy commodities. Now, why is this important? 95% of the family planning program in Malawi is financed by donors and multilateral support. And this is through international organizations, it's through NGOs, it's through different mechanisms, including direct support to government. But in this current climate where funding is stagnating from the international community, the call for domestic financing for countries to stand up and put money towards family planning is becoming increasingly louder. And Malawi was the first ahead of the pack to put this budget line in the national budget as a start, as a commitment to show that they were committed to domestic resourcing. For now, as Mary is saying, for 2022-23, we have come to 475 million for commodities. So we have come a long way, but it's been political will. It's been support. Under health financing, if we're still looking at domestic financing, government really provides direct support to family planning programs, which means they are looking at operational costs. They're looking at salaries of the health workers. And in 2017 alone, I mean, they had even surpassed what we had put as a whole CIP program, only that it was direct support, and they had put 7.2 million towards direct costs, which is a cost share mechanism to the other money that the partners had put in terms of programming now, the indirect costs, the information, providing people with information, providing people with access, providing people with the agency, the capacity. So the programming costs have been borne largely by partners, but government has stepped up to at least provide for the direct costs. So we are getting there slowly with domestic funding, and we have to be strategic in the way we think. The health budget is very slim. And yes, we want domestic resourcing, but we have to be smart about where is this resourcing going to come from when the country can generate no more money towards its budget. And so partners, again, have sat down with government and supported programs to kind of look at how do we maximize the little resources that we actually have. And we now have a health financing strategy, which is 2020 to 2030. And in there, we're really looking at how are we efficient with our money. And Mary talked about some of the efficiencies. Let's look at quality. We don't need somebody to come 3 times to a clinic because the first job was botched, because they got the wrong commodity, because the service provider was just not aware of what they were doing. That's wastage. So we have to be efficient. We need to target the areas. So quality is the first thing. We need integration of services, and we've talked about that. Making sure that we don't have these vertical programs, which also puts strain on the beneficiary at the end of the day, and we're here to serve the beneficiary. So we can't have a woman coming to antenatal on Monday, family planning on Tuesday, HIV on Wednesday. We're not being efficient with our resources. We're not also respecting the client's rights and needs and time. And so we're looking at integration. So you'll be hearing government talk a lot about integration, but it's a health financing mechanism to make sure that we have one-stop shop and we're providing quality services and we're not wasting what we have already. We're also looking at issues of harmonization. Like, how do we harmonize some of these policies? Even amongst ourselves as international agencies or whatever, we may have a fragmented agenda. But now the discussion is how do we make sure we have all these agendas harmonized? And these are some of the things that the ICPD does. It makes sure that we are tackling issues of gender-based violence. We're looking at health, we're looking at development, youth empowerment. So it brings us all to the table at one time, whereby our health finances are then more efficient because we're not duplicating, but we're complementing services that are essential to reaching out to these young people. Under the same efficiencies, we need to target youth, and that's where the critical piece is. The youth are here today. The youth have the agency today. The youth need to be elevated today. Why do we say this? In the health financing, you'll find that youth should be a part of the planning. They should be part of the implementation. They should be part of the monitoring, because this is more efficient. Sandra is 100 years old, and I'm programming for Jane, who is 20 years old or 15 years old. I have no clue in terms of how they want to access their services. So if we're going to be efficient with our resources, we need to bring those beneficiaries to the table. And right now, those beneficiaries are young people. And they are not a homogeneous group. They are married, they are unmarried, they're in school, they're out of school, they're age 10, they're age 15. They have different genders. We need to respect these and make sure that we are programming and targeting them so that we are not wasting resources by issues that don't resonate with access to young people. We also need to look at accountability, which is a critical piece to the health financing or resources for the country. How are resources for family planning being used in the country? And therefore, government has partnered with civil society organizations to give them that mandate to be able to exercise their right to hold governments accountable where inefficiencies are not happening. And so that's been a key success in the family planning program, where civil society will advocate for more resources. Civil society will question government. Why are you not using the resources that are allocated to you? Civil society will empower MPs to provide their oversight role. And this has been a critical piece in the financing for family planning, which has brought us up to this 475 million kwacha that is now in the national budget. So civil society has been critical in the success of financing. But accountability and transparency go hand in hand. And I think the other area that we have done well in Malawi is digitizing access, real-time data. So international organizations have supported governments such as CMED, HTSS, and the others to have tools that allow people to track commodities to the last mile. They have tools that you can actually see which facility is stocked out. So the digitization and evidence-based planning or evidence decision-making has been critical in the Malawi success story. And these will need to be increased as we go along for real-time data, and that not just certain individuals, but everybody should actually have access to information. But COVID-19 came and taught us quite a few lessons as well in terms of financing, continuity of programs, and how gains that you make can quickly be broken. So for example, when we closed down schools during COVID, we saw the spike reported by you, the media, in teenage pregnancy, for example. And why did that happen? Because we were so focused on COVID, we forgot that life continues and that our services were interrupted. And so we had to be efficient again to say, well, even in a time of disaster, life goes on. Family planning commodities are essential at any disaster point, at any emerging pandemic. And we were quick then to restore services, use the door-to-door services, use the CBDAs, use the HSAs to try and reach these pockets of young people being affected. But it did teach us a lesson. And this is a critical lesson for any sustained program. We cannot, in an event of any disaster, in any pandemic, stop the services of family planning or any health service in that sentence, because life goes on. So we have adopted the policies that were developed during COVID to ensure that these systems and structures are still happening. And I think at every level now, within the health facility, within the education facility, within the gender aspects, within the health youth aspects, we have seen the critical role that family planning has played, and we are stepping up to the plate as the country. And from going forward now, Malawi will use the health financing strategy with all these issues that I have said, the efficiencies, the integration, the quality, the transparency, the accountability mechanisms that will continue from now until 2030, so that we continue to have the domestic resources, because if the 95% of the government, of the donor community resources are removed, and we only have operational costs, then we don't have a family planning program. So we need government to now look at the next step. Yes, you are putting money for commodities. Yes, you are putting money for salaries. But now what we want is money for programming, so that we can be assured that this generation and the next generations to come will live healthy and productive lives. Thank you, Mr. Chair.
Very much, our esteemed guests. This is a very candid explanation. At least for once, we're coming up with a very successful whereby the people of Malawi can celebrate. Now, colleagues from the media, the floor is now open. What we're going to do, you introduce yourself and the organization that you represent. Afterwards, we're going to have one-on-one interviews, because most of our clients or our target audience would also want to hear the success story in Chichewa. So I assume that we're all going to be able to take Chichewa interviews. As for Madam Rodriguez, I think Madam Longozi can do it on her behalf, so that the audience, who are in majority, can be able to appreciate and also be part of the success story and celebrate with us. So colleagues, the floor is open. Introduce yourself and the organization that you represent. Looking at the subject, the way it has happened, we are going to take about 5 questions, because most of the issues have been explained, and we'll just dwell on the one-on-one interview. Who do we start off with? Yes, pass the mic at the back.
Good morning. My name is Brenda Puliani from Nation Publications. My question is to Ms. Rodriguez. You mentioned that you, as UNFPA, you ensure that there's zero stock out of family planning products. I was in Cheo a few weeks ago, and I met a few people who are now pregnant, unplanned, and there were some who have aborted, apparently, because for a long time there's been no family planning supplies. So I wanted to find out what the problem is, because I think it's been a while since this issue has been in the public domain. Thank you.
My name is Meglina Chira from Timveni. My question is on the adolescents, and the question is going to Mr. Zulu. You made a mention that as a country we are doing well in terms of providing contraceptives to the adolescents, but still there are some gaps. What are the gaps, and what is it that you're doing to address the gaps, or what do you intend to do to address them? Thank you.
My name is Eunice Rovo from MBC. I'll just build on what she has said, because I wanted to ask something to do with that. Looking at the adolescents here in Malawi, they don't access family planning as freely as they would want, mainly because of policies that are not talking to each other. I can give you an example of a 10-year-old girl that can go for antenatal but cannot be accepted to have contraceptive. What are you doing to deal with such issues?
Good morning, Chimwemwe Padata from Zodiac. I have two questions. One goes to the UNFPA country representative. You've said that the unmet needs on family planning for adolescent girls is still high. What else are you recommending apart from ensuring that there is zero stockouts of the products? So one question. Another one goes to Propel Malawi country director. Just wanted to understand from you, you've mentioned about 95% of unmet of donor money comes from the donors for family planning. I just wanted to understand, is out of the allocated for about 400 million kwaja that was allocated? Just wanted to get the figures right. Thank you.
My name is Leonard Masauli from Mana. My question goes to Madam, is it Malumbira? Or Malumbira? Yeah. I'm looking at access to the sexual and reproductive health services, especially in the rural communities. How accessible are these services? Because I was once in Elikoma district, and I think it is one of the area which is very hard to reach because you have to pass through the lake. How accessible are these services to the hard to reach areas?
Our esteemed guests, you cannot take the questions afterwards. We can do the one-on-one interviews. I've noted that all the questions have been in English. I'm surprised what's happening because I thought maybe the likes of Kathy Maulido were going to chip in one Chichiwa question. Yeah, please.
Okay, ndimafunsa kuti makamaka ndifunse ku mbali ya boma komanso anzathu amene mugwira ntchito mothandizana ndi boma nkhani ya family planning kapena kulera. Nthawi zambiri mapezeka kuti achinyamata ndi amene amavutika kuti apeze njira zolera, makamaka chifukwa chokuti pena amakanizidwa ngakhale kuti malonso okuti akatengere njira za mavuta, pamene mwana mtsikana kutenga mimba ulali ndi zaka zocheperapo mwina 10 kumapita mu mtundamo amatha kulandiridwa ku chipatala ndi kumapatsidwa chithandizo ku sikelo ya azimayi apakati. Nchifukwa chani timatha kulandira mwana ameneyoyo bwinobwino, komano pa nthawi yoti mwana uja akufuna prevention tikumukaniza? Tikuchita chani pa nkhani imene? Ifuna ndikuona ngati mwina ndi ndondomeko zina zomwe zilipo za boma zomwe zisakuyankhulana bwinobwino. Chikuchitika ndi chani kumbali imene?
Thank you very much. I think now we can take the questions, and our guests feel free to respond in any of the languages that you feel will do the magic in terms of communicating the message to the audience.
Thank you very much, Mr. Chair. And of course, I am not yet able to speak Chichewa. I will be, but not yet. And I agree that if we can speak in Czechia, it will be better. But let me just bring some few points, and then I will pass to Ms. Mulembe, because I think that Minister of Health is best placed to answer some of the questions. One of them about the stock out on family planning commodities. I think this is always something very important to pay attention. Being it real or perceived, or because of a health worker that might not be very well prepared. Sometimes this can happen even when we don't have the stock out. So this is something that we need to understand. For UNFPA, whenever this comes to our attention, what we do is to approach the Minister of Health to try to understand what is happening and how we can help if there is a stock out. Sometimes it is something that it is in a specific area because of very specific issue or situation. It is always important to investigate and to understand why is happening. Even if you have one girl coming to us saying that I couldn't have access. But I think the Minister of Health is best placed to respond to this specific case you have mentioned. Allow me to answer one question also, if I may, that came from Zodiac, I think, related to the unmet need for family planning. So it's of course, it is not only the zero stock out, which is on family planning commodities, that is important. When we talk about adolescent and youth, I think all of us, we have been talking about this, and we are practicing it. And Minister of Health is practicing it with the support of many partners, is to have a very holistic and integrated approach. So we are talking about issues linked to education, to their right to access a full and comprehensive health service and information. For example, we have the youth health-friendly space, which is something that tried to provide this kind of services. We are supporting. From UNFPA point of view, we have some programs, namely supported by COICA, working with the out of school, because it is, as I said, it is something that it is linked to the access to education as well, where we try to bring the comprehensive sexuality education in the way that it is accepted in the Malawi reality, but it is focusing on teens. We have the joint program in school for information sharing, youth information sharing, etc. I will not go through the list because I think we have many, many interventions that look at this on a very integrated and holistic manner. But I think the Minister of Health is best placed to respond to some of those issues. Thank you.
Thank you very much, and thank you for this question. Actually, as the ministry, yes, I was. At the ministry, when I was talking about our phased approaches, we also employed the issues of actually adopting the various technologies as related to family planning and contraception. So we have a family planning method mix. We put all those contraceptives like in one basket. So we have categorized our methods. We have the short-acting and reversible contraceptives. This covers the implants for 5 years, one for 5 years, another one for 4 years, and another one for 3 years. And we have the IUD, also known as loop. So this one, a woman can use it for 10 years up to even 12 years. And as a country with the technology, we are bringing another brand that a woman can use for 5 years or 7 years, and another one for 3 years under the IUD or loop. We also have the permanent methods. So under the permanent, the category 2 permanent methods, vasectomy for men and tubal ligation for women. Then we have the short-acting methods. Under the short-acting methods, we have the the emergency contraception. We are now calling it njira ya pompo pompo because the guideline has changed. You don't have to wait for maybe an instance to happen to have the method. You can take it in advance before the incidents. So we also have the injectable ena amanena kuti depo, which actually a woman gets for every 3 months. We also have the pills. We have the pills, we have those, the 2 categories of the pills in addition to the emergency. We also have the male and female condoms. So I think, which, I don't know with this lady who went to Uncheu, which method was she looking for among our full basket of contraceptive methods. We slay to find that all the contraceptive methods are not available in one facility. But maybe issues to do with what she actually wanted. And apart from these methods being found and not being found in at Ncheu Decho, we also have FIPAM clinic at Ncheu where she could have gone and accessed the methods. In addition to this, we also have the community-based workers. We have the HSAs who actually give the injectable and the pills and condoms. We also have the youth CBDS, the community-based distribution agents. So we have those who are supporting the youths, but they can also support the adults. And also we have the adult. So we have various methods that a woman has to choose. If one is not available, she can be supported to choose the other method. We have various sites where they can get this, even over the counter. In some shops, if we go to PTC previously, we would find that the products are there. We go to the pharmacies, we find that the products are there. So, and also our colleagues, you can support us to say, if they're saying we don't have the methods, support them to say which are the methods. There are so many methods, which ones go and make sure that you choose. So, yeah. And also on the issues of the products, we are supported as by government, by the products that are procured through NFPA and also USID Chemonics. So the products which are procured by UNFPA are issued to government through the central medical stores. And as government, we coordinate the distribution plan, how much each facility should actually get, and we work together with the central medical stores to ensure that the products are issued, and work together with the structures at the district level to ensure that these products are available. So they just procure for us, and we work together in coming up with a plan. They procure, they actually live at central medical stores, and we coordinate everything. So we make sure when our distribution, we distribute all the available methods. Ndingo yankhulapo kuti njira zathu ndi zambiri, tili ndi zambiri zapankono, zalupu, izi timati zokhalitsa, komanso zimene mayi amatha kusiya ndikutenga mimba. Tili ndi njira zamuyaya zimene ndikutseka kwa amayi, kutseka kwa abambo. Tilinso ndi njira zogwira ntchito nthawi yochepa, ngati panopa tili ndi njira ya pompo imene matchedwa kuti emergency contraception. Panopa azimayi ola achinyamata akumatengeratu njirayi asana pite mwina kukapanga nchitidwe ugonana. Tilinso ndi mapiritsi amphamvu imodzi, mapiritsi amphamvu ziwiri. Ndiponso ngati achinyamata akhoza kutenga njira ya pompo emergency imene panopa so ambiri akuitenga, even akhoza osotenga mapiritsi njiraso even zapadzanjazi mayuthi akhoza kutenga. Tilinso ndi makondomu. Njira zindi zambiri ndiye mafunika so azimayi athu tikamakumana nawo azathu amidiya muzitithangatira kwa uzoti koma njira zindi zambiri inu mafuna njira iti. Ngati njira imeneyo palibe athe kusankha njira zinazi. Ndikhulupirira kuti tayankha. Komanso kuli malo ambiri kumene angakathe kupeza njirazi kuzipatala zathu zaboma, chapaboma, komanso zimene zili m'madera awo mene timati ma health center. Akhoza kukazipezaso ngati kunchewu kuli FIPAM clinic. Komanso tili ndi ma volunteer kumudzi kumene akhoza kukatenga njira zimenezi. Now coming on the second issue on adolescents not accessing services. This is the issue that we also have to work together as a media, commerce, our stakeholders. We actually understand that the our Malawi Constitution regard some of the adolescents as minors, and that they have to seek consent. And also, there are also some clauses in the same where if a provider has failed to provide the services, that minor or whosoever is a provider can take that provider to task to say, I went for the services, I not provided the services. So we are working together, want to work together so that we ensure that we actually able to create a friendly legal and policy environment. Much as we understand that they are minors, if we go to the Ministry of Gender Policy, maybe also the other guidelines, age for consent for marriage is at 18. If we still also have to go through some of the Ministry of Gender policies and the child protection policies or maybe acts, we learn that age for consent for sex is 16 years. And if we go to the HIV policies and supporting documents, we also learn that the age for access to HIV ART services is at 13. But we don't have a clear age for access to SRH services. Yet in our health sector strategic plan, in our SR sexual and reproductive health policies where there is family planning, we promote access to all. So this is an area that we need to work together to actually address the gap in the legal and policy framework so that we have actually a clear age for access of these services. So that's why maybe our adolescents, some of them, they are not able to actually access our services. If providers give them the services, they are being brought to task. They are being summoned on this. So this is the context that we are in. But as according to our policies and guidelines, the sexual and reproductive health policies and guidelines, and also the universal health coverage, we are promoting access to all. Ndikuyankhulako nchichewa kuti achinyamata ena sakutha kulandira njira zathu katenga njira zathuzi. Tili ndi ma issues zokhudzana ndi mwina makolo sakuwalolera eti komanso tikapita m'malamulo mwathu mu constitution amanena kuti amene ndi mayina amayina kubwera ndi bambo ake mayi ake kuzatenga njira zathu zolera. Komano tikaona ngati kwanza athu akujenda ndi ma supporting documents tinabwera ndi lamulo loti mtsikana kapena achinyamata nyamata kapena mtsikana ali ndi ufulu osankha kulowa m'banja atakwanitsa zaka 18. Komanso tikapita kujenda komweko ku child protection tikumva kuti achinyamata kapena achitsikana akhoza aloledwa kuyamba kuchita mkhalidwe ogonana atakwana zaka 16. Tikapita kwanza athu aku HIV policy and supporting documents timaona kuti achinyamata apena anyamata akhoza kulandira chithandizo cha HIV ndi mankhwala ama ARVs paokha atakwana zaka 13. Koma tilibe ujeni zaka zimene achinyamata awa angathe kuchita kukalandira njira zathu zolera. Ndi pamene tsopano ifeyo ngati boma tipempha kuti tigwire ntchito ndi anzathu a media ndi anzathu mabungwe kuti tionetsetse kuti tikambirane tichite tikumane ndi anzathu a local commission tithe kuchotsa baliya kapena choletsa ichichi pobweretsa zaka zoyenerera kuti achinyamata awawa ngati akuloledwa mzaka zochoka pa 13 kufika ku 18 kusonyeza kuti akuchita ulede akutha kugonana tikhale ndi chaka jeni wero clear kapena chaka chimene angathe kuchita akalandira njirazi. Amatha kupita ukalandira koma amapezeka kuti akubwezedwa, amatha kupita ukalandira koma amapezeka kuti makolo audindo akutengera anzathu ogwira ku chipatala ku makhoti ndithu ndi zimene ndi ngafune kuwonjezerapo komanso anzanga awonjezera zikomo kwambiri.
So of the 95%, I only have one question, so I'm not. So the 95% is the total program budget for family planning. The 475 million that the government gives for commodities is just like an add-on to that. Yeah.
Maybe just to add on this issue about adolescents, because that's really the place where the biggest gap is. And I think as my PD here said, the ministry is trying all it can. One is the issue about sorting out the conflicting policy or legal statements surrounding this issue. But also a lot of times it's when we do research in this area, we find out that what our colleague there talked about, what she found in Shell, that the providers have their own attitudes. They make, even when the government has a policy, as Mrs. Peely said, that the government doesn't have a policy that says you can't give family planning to anybody who wants it. The providers, maybe some of them are parents, they see a young girl or a young boy, they are like, why are you doing this? So they make their own determinations, and part of what the ministry and other partners are doing is also to train the providers so that they understand that it's not about their personal views about these issues. It's really about the government committing to ensure that there's universal access to reproductive health services by everybody. But one key issue also about young people, evidence has shown that if young people are provided with information from a young age, age-appropriate information, comprehensive sexuality information, that at the time when they are making a decision to be sexually involved, then they make the right decision. They may demand that they should use contraception, or they could say no, depending on the circumstance and so on. But we have in Malawi a big challenge relating this, in that our curriculum in the Ministry of Health really has not fully embraced comprehensive sexuality education. So when you talk to our colleagues at the Ministry of Health, they are pushing for this. People at the Ministry of Education are very categorical that they want to limit quite a number of things regarding this. So I think it's very, very important, if we really have to protect a lot of the young people, that key stakeholders, but with the leadership of education and health, that we should really resolve this issue and make sure that we come up with an appropriate, age-appropriate, comprehensive sexuality education. Thank you.
Mwina dinaiwala kuku. I had one question on access to rural areas, mostly in Ilikoma. So we already know that from the ministry, the services have to be delivered at each district council, and Ilikoma is one of the district councils, and that even the government also gives ORT resources for the district council and the district hospital, and to provide, to support the nearby facilities. So even the partners, when they are supporting the ministry and even supporting the districts, they also have to ensure that by the time they're leaving, we are able to sustain the services. So in Likoma, there is the district council and the district hospital, who actually oversees the provision of services in all the areas and also along the lake. They also do have outreach clinics, and as the ministry also supported coming up with the providers, the community health workers, to provide the services. Kulima HSA amena kupeleka ma services ku community. Komaso tilindima CBDs, ma community based distribution agents. Komaso akudecho ndololedwa, komaso amapita kukapeleka ma services. Ndi tikakhala tili ku community, let's also support in creating awareness so that the communities are able to actually have the services. Even in Nkatabe, they do have programs, many amakhala ndima outreach services, and how amanyamuka mwina 1 week akupereka ma outreach services along the lake. And Nkata Bay is also well supported by UNFPA. Kumene kuko and timampatsidwa ma resources amene amachita manage ndi machita conduct ma outreach services. Timadziwa kuti ku Nkata Bay kuli terani yovuta, so they also do that in addition to support imene amalandira kuchokera ku boma and also Ministry of Health. In terms of the animate need imene tinachulidwa, indeed animate need ndiye kuti sitikutha kuafikira. We are not able to reach out to the adolescents with our contraception, so ili high among the adolescents. We have the ICPD commitment. Many muli at after 25 years, tapangaso committee. From the 1994 commitments, tapangaso committee to the ICPD commitment. Tinapanga in 2019. Ndi 10 commitments. You'll be shared the documents. Kumene tukuona kuti panopa ife tufuna chita address animate need for contraception. Amene situkuafikira. Komanso tufuna kuti osango titenge okwati wawoka koma all women. Amene ali pabanja, amene sali pabanja koma amachita nkhalidwe ogonana, komanso ma adolescents achinyamata. So tikapanga categorize timadziwa kuti animate need imene ikuoneka kuti ili pa 22%. Ndiye tikufuna kuti kumafika chaka cha 2030 tichite reduce kufika pa 11%. That's why till here working together, being supported by various partners, and also AFIDEP actually supporting us with the research, and the Anzatwa information supporting us with information giving, and Anzatwa media trying it also kuti zimene mwamva pano muzitenge mukatiperekereso kwa ma beneficiaries. I think it tayanka my questions also. Thank you.
One last point, Mr. Chair, I can note is I think part of this issue about making sure when you are at a high level of contraceptive use, there's the issue about reaching the last mile. The people, how do you identify the people who are most left behind? One critical feature about Malawi's success story is that if you look at over the last 30 years, Malawi has done very well in reducing inequalities. So the difference in contraceptive use between the rich and the poor, the urban and the rural, those who are less educated, there are still differences, but these differences have narrowed down, which means that the program is really trying to reach the all corners of the country. But there are still gaps there. And I think part of what maybe needs to happen now is that family planning is still mainly delivered through the health service system and with community health workers and so on. How do we take it, how do we make sure that other programs in government are also contributing to family planning? You look at agriculture extension services, those who are already reaching farmers in various areas, whether it's people working on conservation, climate change, how do we make sure that other sectors also see the development value of family planning and integrate family planning in their programs, not only doing integration in health? So at AFIDEP, we are now working actually on a program where Malawi is one of the focus countries. It's a global program where we are trying to help government and various actors on how they can integrate family planning. It's called BUILD. It's also funded by USAID. It's really how do we promote integration, because in the end, if we just leave this maybe to the health sector, then they are ensuring that nobody is left behind, that everybody actually has access to family planning may be hard, especially in areas where people are even finding it hard to get to health services. But I think one last point I wanted to say is I think this story is remarkable, not only because other countries can learn from what Malawi has done, but also I think in Malawi there's this big question about what makes change in this country, what helps to address development bottlenecks. And I think the lessons that the family planning program has put on the table, the political will. In many countries, you even see maybe presidents come and talk about family planning, but in Malawi, we haven't had that sort of, the political leadership has left the program to run without interfering with it. There's the issue about the policy environment, all the policies that we've heard about here, but more critical is that partnership between government, private sector, development partners, and so on. So I think for me, it's not just about what other countries can learn regarding family planning, but what can other sectors in Malawi learn from this experience to see how we can emulate this success story, whether it's in agriculture, whether it's in fisheries, and so on. So I think we need to embrace this, and the learning can be local as well as external. Thank you.
Thank you very much, our esteemed panelists. Now we're going to give you 3 minutes to summarize all what you have said, or maybe a brief synopsis. We're going to start off with Madam Rodriguez through her, I don't know what term I can use, through Ms. Lunguzi, because we want everything to be in the vernacular. Yeah. Afterwards, it will be Madam Piri, then Dr. Zulu, then Madam Mapemba.
No, zikomo kwambiri uthenga umene unali pano ndiwakuti ife tikusangala nawo ngati UNFPA pa nkhani imene Malawi yatchuka pa dziko lonse kunena kuti pa nkhani yakulera dziko la Malawi luchita bwino kwambiri. Ife akubungwe ya ku UNFPA ntchito yathu timaonetsetsa kuti zimayi aliyense watenga pathupi chifukwa choti akufuna nthawi imene amafuna ndipo abereka mwana bwinobwino opanda vuto lina lilonse. Koma kuti zimenezi zitheke nkhani yakulera ifunike ikhale patsogolo chifukwa munthu sangabereke moyenerera nthawi imene akufuna ngati ali wachichepere, chifukwa ana achichepere tudzoti akabereka ali ang'ono amapezeka kuti abereka ali ndi mavuto ambirimbiri, nkona mamva kuti zimayi wamwalira nthawiyo imene akubereka ambiri amakhala achichepere. Ndiye tikuti ife katemera wina opangitsira azimayi asamapeze mavuto ngati matenda a fistula ndikuti adzipeze kuti abereka nthawi imene akufuna. Pamwamba pa zimenezo ntchito ine imene timagwira a UNFPA ndionetsetsa kuti azimayi asamapeze nkhanza zosiyanasiyana. Nthawi zina azimayi oti chaka chino mwana, chamawa mwana, chinacho mwana, umapeza kuti chitukuko sakupanga nawo, amuna amene akumamuthawa kuti angokhala ndi ana mbwe. Ndiye kuti zimayi uja enjoy, ife tikuti zimayi atetezedwe polandira njira zakulera nthawi yoyenerera. Ndiye ife a UNFPA china chimene timapanga ndi chopereka mauthenga osiyanasiyana kutsera mapulogalamu osiyanasiyana. Nkhani mwamva pano akuti achichepere bwanji, ife timagwiranso ndi unduna wa achinyamata kuti mwana kuyambira pa dzaka 10 amve uthenga oyenerera kuti koda angatani kuti asatenge pathupi, angatani kuti asatenge matenda opatsirana pogonana onjezerapo AIDS. Ndiye ife timagwira ndi achinyamata ku sukulu ndiponso amene asali msukulu. Pamwamba apo ife akubungwe la UNFPA tugwirizana ndi ma donors osiyanasiyana ngati a British government, Germany, Norway kuti tidzipeza ndalama zoti tidzithandizana ndi unduna za umoyo kuti tidzigula njira zakulera zisamaso imene mwanenera inu kuntcheu kuti zikusowa. Koma zimene zizife chimene timapanga nchoti ngati chifukwa choti timagula dziko lonse UNFPA timagula njira zakulera zakolite zopanda mavuto ena aliwonse, andi timakapereka mpana pakhomo pamene pali munthu amene akuzifuna amene anenera anzathu akunduna zomwe kuti kuli ma CBT Community Based Distribution Agents mapulogalamu athu amaonesa zimenezozo. Ndiye tasaina mgwirizano ndi aboma compact oonetsetsa kuti tisamangodalira amabungwe kuti atigulire mankhwala, koma ifenso aboma adzikapo ndalama. Ndipo nchonyaditsa kuti boma la Malawi chachino lapereka 400 million yoti igulire njira zakulera. Ndalamazo atipatsa la UNFPA tagula kale njira zolerazo, ndipo nthawi ina iliyonse tionjezera pa zimene tagulazo kuti zitifikire. Panali mafunso osiyanasiyana oti koda achinyamata tingatani kuti tathandize. Ife mmene nene tili mapulogalamu osiyanasiyana oonetsa kuti lidzafikira anyamata ku sukulu mpana ku sukulu. Koma chimene tingathandizane mmene anenera Bambo Zulu ndiye nawo kuti azathu amabungwe a education tidzionetsetsa kuti uthenga wathu udzikhala umodzi, osati lero tunena kuti izi ayi sukulu izuka ana amapezeka ku sukulu tingatani kuti tathandize kuti tapatse information yoyenerera. Pamwamba apo tifunanso kunena kuti tikapeza kuti mankhwala sakupezeka suti amakhala kuti sakupezeka kwiniko ngati kutchewu kulibe upeza kuti kudedza alipo komanso timayesetsa kwaphunzitsa opereka ntchito aja kuti adzidziwa kuti kodi mankhwala akasowa tingapeze kuti amati pull and push uthe kuimbira nzako kuti kodi kumeneko muli nazo njira zolerera ndiponso ukathe kutenga momwe tingodikira kuti zikupeze ndi zimene ndinganene mwachidule pokambirana zikomo.
Zikomo kwambiri. Boma la Malawi likuonetsetsa kuti ndithu mzimayi aliyense pachichewa timati akazi pa akazipo amene sanakwatiwe koma amachita nkhaidwe ogonana amene ali pa banja komanso achitsikana timatha kale kumanena kuti uchembere ukuyamba zaka za 15 ukafikira 49 koma panopa tikuona kuti uchembere ukumapezeka kuti mwina wa zaka 10 kusanza kuti mwina zaka 10 mpaka na 14 nawonso tikuwatenganso ngati amene angathe kulowa mu uchembere. Ndiye tikufunitsitsanso kuti achinyamata komanso abambo amuna azibambo akuluakulu ngakhale achinyamata athe kukhala ndi ufulu osankha kutengako mbali kugwiritsa ntchito kugwira nawo ntchito njira yolera kapena achikondi awo athe kugwiritsa ntchito njira zathu zolera. Tili ndi ma policies abwino amenenso ali kalenti okhudzana ndi nyengo zimene tili nazo panopa. Tili ndi ngati achinyamata tili pa mgwirizano kudzera mu AGYW strategy timati adolescent girls and young women strategy. Uwu ndi mgwirizano mene uli pakati pa Ministry of Education, Ministry of Youth, Ministry of Gender ndi Ministry of Education. Ndithu akuluakuluwo tili ndi strategy imene iyi tiliso ndi panopa achita revise the National Youth Friendly Health Services Strategy. Tikuthaso kufikira anzathu achinyamata achitsikana amene ali mu higher education institutions because zimene konso tinaona kuti sitimafikira. Ndiye tili ndi mabuku amujeri mapolisi athu abwino komanso tili ndi support yochokera ku mapartners monga mmene mwamvera amene akuthandiza kutipatsa ma resources komanso support technically komanso research ndiponso tikuthandizana kuti tikutha kugwira ntchito ndi anzathu ma CSOs aku parliament mabungwe onse tikugwira ntchito limodzi. Tingopemphaso a media kuti mutengeko mbali kuti tithe kuthangatirana ndicho linga chakuti tikamadzafika 2030 komanso kandi 2063 tidzaone Malawi osinthika tasamale achinyamata amalize skulu adzathe kuthandiza chitukuko cha dziko lathu lino. Zikomo kwambiri.
Thank you. I just want to leave maybe with this statistic, right? The median age at first sex in Malawi is 17.2 years. Sometimes when we say average, we tend to not internalize what it means, but what the median age means is that half of our girls, by the time they reach age 17.2, they have already had sex. The median age at first marriage is 18.3. Our law in 2013, we all celebrated that Parliament passed the law to say that the minimum age at marriage is 18. But according to current data, half of the girls have married by age 18.3. So I don't think that we can say everybody is waiting to marry at 18. There are still many people marrying even before the age. So we have an enabling policy environment, but I think it's about implementation, it's about enforcement, and this has to be done by they say it takes a village to bring up a child, right? It's the government has a role, civil society, the media, and everybody. And I think the other thing, I talked about how everybody out there was talking about Malawi has done well in family planning. The big question that many of us are getting out there is what is happening in Malawi? The population policy is still, which was supposed to be renewed 4 years ago, is still in the doldrums. So I hope that this good example that we have as a country that is now an exemplar, that we continue to make sure that policies are renewed in a timely manner and we deal with all these issues. But really for me it's just to say, to really congratulate the ministry who are our primary leaders in the Ministry of Health, in the family planning work, and all the development partners on the table here and many others there, whether it's FIPAM, Banjalan, Sogolo. There are many organizations. It really took a collection of all sorts of organizations to achieve this. But the critical thing we need to note is that this is not a one-off achievement. There are many countries where contraceptive use has gone up, it has stalled, it has even gone down. So these issues about stockouts that you talked about, the young people in Shea who found out they couldn't find family planning. If we don't sustain the funding, if we don't sustain the partnership, it's possible that this progress can be reversed. So we have to sustain it and close the gaps that are remaining. But I think the fact that we've achieved what we have so far means that we can actually continue being an exemplar for many decades to come. Thank you.
Yeah, ziko. I think zimene timakambirana panopa ndi thumba la za ndalama kuti kodi kachitidwe kapena ma international organization amathandiza bwanji kumbali ya thumba la za ndalama kapena as a family planning program ku Malawi. How are we financing this? Then ndimakamba papa kuti kwambiri kwake kuti program kumbali ya mwina ma information kazimena anakamba Juliana kupanga engage ndi ma CBDA kaya ndipanga training tayi zambiri 95% of ndalama imeneyo imachokera kumabongwe ma donors kapena ma bilateral partners. Aboma kwambiri ndalama zawo zimapita kumbali ya masalary kapena kugulako pang'ono kubenthulira tima commodities kuti tizioneka kuti Malawi ndithu nafenso tikuchitako kenakake. Nde kwambiri kwake tikuona kuti ndalama za anzathu ma international organization zikukhala ngati zikuperewera. Ndiye ntchito ina imene akuthandizira ma international organization zikuthandiza kuti ma CSO kapena ma local organization kapena ma youth organization boma limene liunike kuti kodi ndalama za domestic funding timati ndalama za konkuno Malawi kwacha ipanga bwanji pa nkhani ya family planning. Nde ma program for the next 5 years of course ikhala focus yake imeneyo kuti tithangatire kuti kodi titenga kuti ndalama za ku Malawi kuti anzathuwa akati ya ife tapita program isagwe. Nde Malawi yakhonza health financing strategy imene ikuunika njira zina ndi zina zoti kandrama kamene kalipoko poti tikudziwa kuti ndrama si chuluka koma anthu akuchulukabe, koma kandrama kamene kalipoko kagwiredi ntchito ka family planning. Nde pamene paunika zinthu zina imodzi ndi efficiency timati pa chizungu. Njira imene ndikuonesesa kuti chilichonse chimene titagwire chidzikhala ndi mbali yake, osati lero tangodya sweet tataya mawa atadya sweet so tataya, koma sweet tikadya kamodzi kizikhala kuti ndi quality komanso ikupereka zinthu zoyenereka kuti tikungotaya ndalama kuti yayi tindi ma vertical programs kuti lero mayi abwera Monday ati antenatal, mawa abwera Tuesday ati family planning, unkuja abwera ujeni HIV. Nzimayi ekhayo pa commandant agwirapo nthawi yanji. Ndetu kuti ma efficiency tikhale ndi integrated services kuti mzimayi akafika kaya ndi Monday atha kupeza ma service wonse, koma akabwera athe kubwera kamodzi sikuti so provider yo akale kuti ayi lero ndilibe kapena ngomuza za mwamba kuti olo chipirisi imene atantengeyo akapita sikagwiranso ntchito ndekuti akabweranso. Tikukana zimene zonse tikuti ndalama imene tikuyikapo service providers pereka ya quality, munthu azibwera kamodzi azilandira zinthu nthawi imodzi. Nthawi imeneyo ndekuti nafenso tikutani tikusunga mbali inayi wantchito yonso atha kugwira zina, mzimayi yonso wabwera tsiku limodzi wapita. Ndetu kuona zimenezo komanso tikuunikira mu strategy momwemo akuunikira kuti kuzikhala transparency kapena tiziunika kuti ngati boma kuti tayika 10 million pa tebulo, kodi 10 million imene yagwiritsidwa ntchito bwanji? Nde mbali ina imene tuthandizira ndi ma international organization kuti a civil society organization kapena achinyamata azitha kumawafunsa aboma kuti 10 million imene munapereka inayuzidwadi ku family planning, mwaguladi mankhwala amene mmati mugula kapena chikuchitika ndi chani? Ndi pamene akuyika emphasis pamenepo pa accountability. Tizitha kuona kuti ngati ku parliament anena kuti tayika 475 million ya ma commodities, ma civil society azitha kuafunsa chinamerewo kuti kodi mwagula kapena chikulephereka ndi chani? Ngati pakulephereka tithandize bwanji? Then mmene tikukhala ndi health financing strategy zimene zozo tikuona kuti mwina zitipitisa kusogolo ndi domestic funding imene tili nayo, chifukwa tikudziwa kuti ndi tikapanda kulimbikisa za family planning tikuona kuti population ikukulirakulira, oloka keke kamene kalipopo tizidulirabe tizinyemerabe ndesizikwanira aliyeseya. Zimene timakamba ndi zimene ziko.
Panelists, Dr. Elia Zulu, Madam Mary Piri, Madam Rodriguez, through Ms. Lunguzu, Madam Mapemba, thank you very much for a very well explained session. On behalf of my colleagues from the media, I would like to thank you, and also would like to inform the public that the success story that you're narrating today, it should continue and should not end here, and you should assume that this is just the beginning. Colleagues, that's the end of the presser. After this, you can interview the panelists through on one-on-one, be it in Chichewa or English. Thank you very much.
Thank you. Just a little housekeeping. We're going to have some light meal outside, some finger foods. We are